The views, opinions, and advice in this podcast are not necessarily those of our employers. Medical topics are discussed largely using best EMS protocols. Discussions here should not replace your own services, policies, and procedures. Hey guys, welcome back to the PCHD EMS podcast. Today we're going to be going over a retrospective study that was published in Resuscitation 2023. The name of the study is Association of Small Adult Ventilation Bags with Return of Spontaneous Circulation and Out-of-Hospital Cardiac Arrest. And I'm going to be here with Dr. Northeim and Dr. Bertrand, our medical directors, to kind of discuss the results and what we're going to be doing with them.
Yeah, everybody, thanks for joining us. So this has kind of created a little bit of discussion over the past few weeks especially, but we at Best EMS, when we attended the Resuscitation Academy in about 2019, we decided to go with small adult bags just based on the data that we know that high ventilation rates and high total volumes actually lead to increased chance of death amongst these patients, and high intrathoracic pressures lead to decreased venous return, and therefore those patients have a poor outcome. And a lot of the studies were pig studies, and we had counsel with Resuscitation Academy out of Seattle, Dr. Idris from the ROC Consortium at the time, and we decided to go with the small adult bags. So we have an infant bag and small adult bag. These are small adult for pediatric and adult patients, and therefore lower tidal volumes. So we've had really great success with our Udstein score rising, our overall survivability rising. I think we're meeting more and more survivors each week. Sometimes very tough to keep up with all of them because we're having so much success. And so when this came out, we really wanted to go back and kind of look at the study. And I think Dr. Bertrand will explain some of what they did and how they did it. And we'll kind of see if this is going to change what we do and whether or not it should change what you do.
Okay, so what they did in this study was they took one department, Seattle Fire Department, which is one of the worldwide leaders in resuscitative care, so great department to study. And in the summer of 2017, from July 1st to September 30th, Seattle Fire Department switched all of their large bags over to small adult bags. The primary endpoint was ROSC at the end of EMS care, so when they arrived at the emergency department. They looked at data from before switching over to when they just used large bags to when they switched over after the small bags. Their hypothesis was that they would have increased ROSC after switching over to the smaller bags because of the smaller minute ventilation. What they found in their study was that they had a higher rate of ROSC at the time of hospital arrival in the large bag component of the study. However, there seemed to be a lot of problems with the way this study was done. One, there was no measurement of tidal volume. Therefore, they couldn't measure minute ventilation. They did control for the ventilatory rate well, but if you're not measuring minute ventilation and tidal volume, then we have no idea how much was being delivered.
Right. And I think the other point was, too, is when you talk to the folks from Resuscitation Academy, when they did their initial training on the large adult bags, they always taught to use princess breaths, right? They have their finger up, they use a princess breath. We're not using two hands, we're not putting on our leg. And so when you go and then change that culture and change it over to small adult bag, did they educate everyone that they actually cannot use princess breaths on the small adult bag, right? We have to push more tidal volume in. So I think that's one of the things that if you have a large adult bag and you're doing princess breaths and you go to a small adult princess breaths, obviously that's a big tidal volume range difference. I think the big thing I saw in this study too that we do within PCHD and especially Best EMS is we use a high rate of iGels initially, which I feel like we're getting a better seal. We're able to get better capnography on these patients. And in this study, in the large bag cohort, 2% got iGel, and in the small bag group, 8%. So a very small amount getting iGel. So we're talking about, mass seal. So there's a big difference in mass seal across the providers as well. So you could use a small adult bag with a great mass seal and get great tidal volumes. You can also use a large bag with a ton of leak and get really low tidal volumes. So I think there's some variables that they really didn't control for very well. So if you look at some of this stuff, as Dr. Bertrand said, really the only two things that are statistically significant with their p-value are ROSC at the end of EMS care and survival to admission. If you look at every other piece, which are the ones that we really care about here because we like to meet our survivors, survival to discharge and survival with neurologic intact status, neither one of those has statistically significant p-values, right? Which makes me kind of question the study. Also, what medications did they give? How much medication did they give? Did they give 7 epi? Did they give 3 epi? And did that have anything to do with the fact that these patients didn't, weren't able to be discharged neurologically intact? And we all know if we give enough epinephrine, it's probably going to change our ROS rates and increase them, but it's not necessarily going to create this massive community of cardiac arrest survivors that are neurologically intact that come back and shake our hands. So I think those are some of the things that we really need to think about with this study.
I'm not a study specialist, but from what I understand, the studies that I've read, you have to be careful making, protocol changing practices.
Right, swinging the pendulum based on
retrospective studies. Retrospective studies are a clue maybe, but they're not the end-all be-all of studies. So
And that brings up the point that there's some great potential for this to be a prospective good study. The problems would be measuring the actual minute ventilation and tidal volume, right? Because there are devices on the market that can do that, but they're still really expensive. Yeah. And that would be really the only way that I think you could make this study significant. And also then again, looking at, Utzine scores on these survivors.
Right, and I mean this CPR fraction, that's basically the percentage of time they were on the chest. I mean, between the two cohorts, 93, 94%. So we know from studying Seattle and being a lighthouse community from the Resuscitation Academy, obviously quality compressions are really important. So everything else, when you kind of compare, are pretty even, and I think explained fairly well. I just think the tidal volumes are a really big deal. And I know with training on our Laerdal mannequins, where we're actually, iGels don't work terrifically with the Laerdal mannequins just because they don't get a great seal. It's not a warm, moist environment where that the plastic in the gel is able to kind of seal with the airway. But routinely, using a small adult bag, we're hitting between 4 and 550, which is really a great goal just with bag valve mask and a good seal. And if we're using the large adult bags, especially for somebody that's not paying attention. I mean, routinely, we're hitting very high tidal volumes, 600 and 700, and I think the problem with amongst EMS is who do we hand that BVM to? It's important for us to really make sure that whoever's bagging the patient has extensive training on how to do that, how to get a good seal, making sure that they're listening to the monitor tell you to breathe at 10 times a minute, making sure that if you're using a small adult bag, you're definitely squeezing the whole bag, and if you're using a large bag, you're doing your princess breaths.
And I'll just say that you were talking about protocol changes. As far as we know, the Resuscitation Academy and Seattle Fire Department are not changing their practices based on this.
Right, and I also spoke to Dr. Idris, who really was the DFW area ROC consortium lead back in 2006, and I spoke to him the other day, and he said there's not enough information to change from what we're doing and keep doing what we're doing. So we're going to keep down the route of small adult as more data comes through, hopefully as more blinded studies and more, control type studies come through. Hopefully with tidal volume we can get some more information, but I think it's dangerous to pendulum between protocols and changes. I think it's important to kind of keep the course until you have something that really will change your mind into what we're doing. I know all 8 of the physicians within Best EMS have decided to stay our course for now and follow Seattle and follow Seattle Fire's lead in the Resuscitation Academy and Dr. Idris.
it sounds like until those tidal volume measuring devices, until they become more widely propagated, we're probably not going to see a good RCT that indicates one way or another.
Yeah, so I mean, I think those devices are great, but I think the problem has been cost, and so it's very expensive to have, especially if you have multiple units, having a device that's over $1,000 a piece, and there's a lot of things that we have to purchase in EMS and prioritize, and so buying multiple of these and buying the cartridges, I think, are a big expense. But I think that is something that, especially for training, we've seen it when we went to difficult airway class. We've used it. I think it's a great tool. I think having more ventilation, tidal volume type measuring devices out there on the market to use real time, I think would be great. I think we all have manometers on our bag, and we can kind of look at those compared to some electronic devices, and they're definitely not as good. But obviously, cost is a major issue for all agencies out there. We have to prioritize what we spend our money on.
Yeah.
So.
Thank you guys for joining us, and we will see you guys next time.